there's anything at any point in time you would like to add to what we're talking about, then we'll go. This is just a quick little review from what are the benefits of electronic fetal monitoring. We know that we use this with nearly all of our laboring women throughout the state. We do have some intermittent auscultation and palpation, but most of our patients are on continuous fetal monitoring. Remember that electronic fetal monitoring identifies or is based on kind of the theory that we want to identify and intervene for signs or symptoms of developing fetal hypoxia. We're looking for normal versus abnormal labor processes. Remember that we have a baby that all babies are at risk for some transient decreases in oxygenation throughout the labor and birth process. Certain events or certain chronic conditions can set us up for an increased risk for that. So that's what we're really trying to watch for. Next slide. We know that we have lots of positive outcomes associated with intrapartum fetal monitoring. We know that while electronic fetal monitoring in its early stages was adopted in the early 1960s and was adopted on very small premise of studies, and we're continuing to learn over all of these years about the limitations, but we know pretty consistently if we have a category 1 fetal heart rate tracing that is associated with that fetus having a normal pH, therefore a normal acid-base balance, and therefore not hypoxia or acidosis. We know that the presence of accelerations and moderate variability are also associated with that oxygenated fetus. Can you advance the slide once? Thank you. So while we know that it's not 100%, we do know that we have to look at the overall clinical context of what's going on with that patient. What did she come in with? What other chronic conditions does she have? What other risk factors are associated with that pregnancy and that placenta and that placental function? But we do know pretty confidently that if we have moderate variability and we have ACELs, that we feel pretty reassured that we have an oxygenated baby. Next slide. So just a quick snapshot of, remember that the fetus has that very specialized fetal circulation, that we are hoping that that fetus has mature enough in order to make sure that it is able to maintain its own homeostasis related to oxygenation throughout the labor process. Given that mom, her placenta, the umbilical cord, and mom's and mom herself are all able to provide oxygenated blood to the baby. Next slide. So we remember that with that maternal physiology, we have changes to every physiologic system in the woman's body. And it really is all about making sure that that fetus is getting everything that it needs as far as nutrients, antibodies, oxygenation, as well as get rid of all of those waste products from the fetus. Next slide. So the way that, well, go ahead and advance it. I didn't realize I had other things. I didn't realize that was all like that. Okay, sorry. So we're going to think first about just a normal, healthy woman with the normal physiologic changes of pregnancy. We have just that maternal health and that fetal health, and then we can have acute events that happen during the labor and birth process. For example, a cord prolapse or an abruption happens, and you add to that the labor and the stresses associated with labor, and that can affect our outcomes for both mom and baby. The other side of the coin, and go ahead, I really did not catch that there were animations there. If it's different when we start looking at when we have a mom that comes into us with a chronic pre-existing condition. So we add to her chronic conditions the normal physiologic changes of pregnancy. And so we start out with a mom that we are very concerned about that overall maternal fetal health, because we worry, is that fetus and is that placenta able to function appropriately with that mom's chronic conditions, and how well can we manage that chronic condition? Then we add that to the labor stressors and what are the ultimate outcomes for both mom and baby. So we're going to start with our case. So remember, as we go through the case, and I'm going to make sure that I've got my chat box up and open here. So chat in the box. If you have any questions, or once I ask questions to you about what's going on with this case. So we're going to start with a 29-year-old, gravida 2, para 1001. She presents to labor and delivery at 30 and 2 weeks gestation with decreased fetal movements. She noted decreased fetal movement 5 days earlier and had a non-stress test the previous day that became reactive after almost 2 hours of fetal monitoring and many attempts at fetal stimulation, and she received no other evaluation at that time. Otherwise, she presents today with no other complaints. She's denying contractions, vaginal bleeding, or leakage of fluid. All right, next slide. So we put mom on, can you go back one? Yes, there we go. So we put mom on the fetal monitor. So I know it's a little bit blurry. I could not get it any clearer for us to be able to see. When you look at this strip, I want you to tell me, and let's just do typing in the chat box. What do you see as the variability for this patient? Okay, so I've got a couple of answers, minimal to none. So it does look like we are transitioning from minimal to absent variability within this strip. So automatically, when we first see this is the first strip that we have for this patient, we are automatically very, very concerned about the fetus and the oxygenation capacity for this baby. Is this baby dealing with hypoxia, development of acidosis? So next slide. So as we continue to monitor the fetus, we look at this strip and we see that we have a baseline that is running about in the 140s. I know you're going to have to just trust me on that because it's hard to see those numbers. And then towards the end of the strip, what do you think is going on with this strip? How would you identify this image on the strip? And we'll even zoom in for you if you can go to the next slide, Rachel. So I've zoomed in on the end of this. If this persists, what do you call this fetal monitoring? Go ahead and type in the chat. So I am seeing a category 3. This is absolutely a category 3 tracing. Remember that one of the categories is that we are concerned about an abnormal fetal acid-base balance, and one of those things is sinusoidal. So yes, this is very apparent sinusoidal fetal heart tracing. It's not 100% classic, it's not a full 20 minutes, but where is your level of concern considering this mom came in with decreased fetal movement, and 5 days ago she additionally had decreased fetal movement as well. Okay, so if this is a concern to everyone, are we ready to try to deliver this fetus? Or do you want to sit on this and kind of wait and see if we can try some interventions, or do we want to move towards delivery? I'm saying yes, deliver. Let's get this baby out. All right, next slide, and we'll see what the outcome is. So they did an urgent primary cesarean delivery. Neonatology was present. Female infant that weighed just 2,500 grams, just over that. APGARs were 6, 8, and 8. Infant appeared extremely pale and required intubation immediately after delivery. Her umbilical line was drawn for hematocrit, and she had a 9% for her hematocrit. So this baby was severely anemic. Baby did end up getting a blood transfusion and was transferred to the special care nursery at this facility. So what do we think could be some of the causes for this sinusoidal tracing and ending up with a fetus that is severely anemic, where we did not see any potential vaginal bleeding? There was no vaginal bleeding present for this baby. Do we have any thoughts or ideas for this? Dr. Campbell, I don't know if you want to pop in with just some possible ideas of what could be causing this, those sinusoidal tracings and severe anemia.
Yeah, I was typing, so I was going to try to be a good student and let you just go. But no, I agree. I think sometimes I've seen this exact case before with a maternal fetal hemorrhage of unknown etiology and never did find out what it was. And so you do a Kleihauer-Betke, and there's a huge percentage of fetal blood cells in maternal circulation. The other thing that it can commonly cause is bleeding from a concealed abruption. You can have a concealed abruption. If she has vaginal bleeding, it can certainly be a clinically obvious abruption. Don't see it as much with the placenta previa, but you certainly can see it with a placenta previa. And the other things, obviously, ISO immunization, other things that are going on with mom. You would hope if she's had prenatal care and you've been taking care of her, that you would know if there's some blood incompatibility that could have led to an ISO immunization problem with her.
Perfect. So for this case, go ahead and advance the next slide. This one ended up being one that no one actually expected. This baby had some abnormal PT, PTT, INR, did have normal platelet counts. They did a brain ultrasound 2 days after birth, and they showed a moderate amount of complex extraaxial fluid and moderate ventriculomegaly. The fetal MRI revealed a fetal intracranial hemorrhage. So for this one, this would be one of those ones that everybody was kind of scratching their heads and going back and looking and saying, okay, what could potentially have caused this for the baby? The baby did, in this case, end up being able to be successfully extubated, and they were monitoring this fetus. So that's not one of any of the ones that we would have normally kind of thought about.
And this is a perfect example of, it doesn't take much blood loss in a baby, understanding that their total blood volume is 250 cc's. They can have a hemorrhage like this into the baby's brain or anywhere and lose enough blood to lead to fetal distress or poor fetal status. So that's pretty impressive.
Yeah. Okay. So the next one, we'll have a little bit more interaction. I think the strips look a little bit better. So for our next case, we have a 40-year-old gravida 3, para 1001 at 39 and 4 weeks gestation. She had a history of a prior cesarean delivery for a large for gestational age infant. She arrives to labor and delivery desiring a trial of labor after cesarean. She does have contractions. Her admission exam, she's 1 to 2 centimeters dilated. She denies leakage of fluid or vaginal bleeding and has reported normal fetal movement. She does have a history of uterine fibroids and a history of sexual abuse in the distant past. She did have an ultrasound about a week ago, and the baby estimated weight was 3,768 grams. Her vital signs are listed on the slide for you, all within normal range. Prenatal labs were within normal limits, and she had a negative GBS. Because mom was in early labor, the plan was to observe and reassess for cervical change in 2 hours and augment with oxytocin if necessary. The fetal heart rate was applied externally, and we got this tracing. And I know that not all of our hospitals do trials of labor after cesareans, but some of our facilities do. So that's why we're talking about this. All right, so what do we have? I know it's very, very light in color to be able to see those numbers. It looks like the baseline fetal heart rate is about 155, but my question to everyone listening is, what kind of variability do we have? And if this is what we have for the first 20 minutes, what category would you assign to this? So type that in your chat boxes. Right, so we've got moderate variability. We have A cells present, which I always consider our bonus points. So this would be considered to be a category 1 tracing. She is having some irregular contractions. They are mild by palpation. Our differential diagnosis at this point is she is in early labor. Cervical exam 2 hours later revealed no change, and augmentation with oxytocin was recommended. At first, the patient was amenable to the plan, but then she changed her mind and refused oxytocin and any other interventions and wished to go home. The physician discussed the concerns of the patient, and she and her husband were informed of the risk of uterine rupture with her history of a prior cesarean and a potential macrosomic infant. The patient and husband verbalized their understanding, but refused treatment, signed a discharge form, and left the hospital. Next slide. After several, oh, sorry, that I already read you that. 3 days later, she presents back to labor and delivery with painful contractions. She says her pain is an 8 out of 10 and is requesting pain relief. She is currently 230 and -2. She is hesitant to get an epidural because she believed that that's why she had her C-section in her previous delivery, and she did not progress past 3 centimeters after her epidural was placed on the last delivery. So this is her current tracing. So again, this tracing is a little bit hard to see, but it looks like we are probably in, we have a fetal heart rate of about 170. What variability do you think we have here? So it looks like we're agreeing that we have minimal variability. She is contracting about every 2 to 3 minutes. They need to be palpated for intensity and frequency. In addition to the continuous fetal monitoring, they did change the mom's position to a lateral position. They gave her a fluid bolus. At this point, what are we most concerned about with a patient that presents with this history that is laboring? So what are we most concerned about with this? Correct, uterine rupture. Very good. So we'll go to the next slide. She stays on the monitor. Variability looks a little bit better. We've got some moderate variability. Baseline still 165. So we're on that high end, low tachycardia. Her contractions are now moderate in palpation. She's contracting about every 2 minutes. You can see that the lower line, so there's the 3 tracings that we see. The middle one is mom's pulse ox, just to make sure everybody is aware of that. For the patient, she's been repositioned multiple times. Her cervix is 3 centimeters dilated, but very swollen. She's about 50% effaced. And vertex is at the -3 station. They placed an IUPC in order to determine uterine strength and to rule out arrest of labor. A discussion took place with the patient and her husband about the options of continued augmentation versus a repeat cesarean delivery. The patient and her husband decided to continue with augmentation. So this is our strip 1 hour later. We are not tracing the uterine activity at all in this tracing. Not sure what's happening there. What are we considering is happening with the fetus at this point in time? So we can't determine a baseline. We can't determine our variability. And it does appear that we are having recurrent prolonged decelerations for the fetus. So what is your differential diagnosis at this point? I know it takes, Dr. Campbell wrote, run fast. So we're worried about uterine rupture at this point in time. A decision was made to proceed with the other things that we would think about is rule out cord compression, cord prolapse, uterine rupture. Decision was made to proceed with a repeat cesarean delivery for fetal intolerance of labor. They called the NICU and the OR team, and the patient was taken to the OR for urgent cesarean. This is last tracing is the final tracing of the fetus in the OR prior to delivery. Our baseline fetal heart rate looks like it's about 65 to 80, somewhere in there. We can't tell anything else that's going on. This is definitely a non-reassuring fetal heart rate pattern. So what do you expect the fetus to look like at delivery with a strip that looks the way that we've seen for the last couple of hours? Is this a baby that's going to be beautiful and crying and pink, or is this a baby that's going to need some assistance? So I'm seeing needing NICU care. So you definitely want to have your resuscitation team there for the fetus. So our outcome for this, next slide, is upon entering the abdominal cavity, the placenta was noted to be completely separated from the uterus. The uterus was empty and contracted down. The fetus and the placenta were found in the upper left quadrant, superior and behind the uterus. The head was delivered, followed by the torso within 2 minutes. So we had a baby, female baby that was pale, floppy, and apneic, and was handed over immediately to the NICU team. Baby's APGARs were 1 and 8. The fetus received positive, the neonate, excuse me, received positive pressure ventilation for 2 minutes with a rapid improvement in the heart rate. The infant started to breathe spontaneously and cried. We can see here deep suction yielded copious amounts of bloody fluid. Baby did go to the NICU. Cord pH is a 6.9 with a gas PCO2 of 104.9, a base excess of -10. So this baby did go to NICU and luckily had an uneventful course. But this is the case that we want to have a little bit of a discussion about. When you have a mother present to you that wants to attempt a VBAC, you know, how do we begin to have that discussion with safe deliveries for this patient? Luckily, this infant bounced back pretty well, but it could have been much, much worse in this case. This baby just had respiratory acidosis. Dr. Campbell, if you would like to chat on how we advise.
I think that this is a very fortunate case, and I think that these catastrophic outcomes, this was close to a catastrophic outcome. If she hadn't been at the hospital, or she had been up to the bathroom and hadn't been on the monitor and came back and this happened, this baby would not have survived. And fortunately, these types of outcomes don't happen often, but that's the reason we counsel these patients so intently about vaginal birth after cesarean sections. And they're very safe as long as you do it like this. You do it in the hospital under the watchful eye with the understanding parent that if we see something that is of concern with the heart tracing, that we go right to the operating room. But the risk of something like this happening, fortunately, is low. But they do need to understand. And this cord gas, this was an acute event. If this had been any longer getting this baby out, this baby would not have done well, for sure.
I agree with that. Is there anyone that in the group that is listening that would like to add to this or add to the conversation so that we can pause the recording
or
make comments? Or do you want to hold the comments to the end?
Yeah, why don't we go ahead and I don't know if you have another case or not.
I do.
Okay, why don't we do one more case?
Do one more and then, okay.
Yeah, and then we can
So actually the case that I really, really want to get to, Rachel, is case number 4. So there we go. So So we'll do this case and then we'll just have some time to chat. So case number 4 is a healthy 25-year-old gravida 1 para 0. She presents to labor and delivery with contractions occurring every 4 minutes. On admission, she is 3 to 4 centimeters dilated, 90% efface and 0 station. She did have spontaneous rupture of membranes with clear fluid. So we put her on the monitor. So I'm sorry that this is also a little bit blurry. There's a balance between trying to make it big enough and keep it from being blurry to see, but we can see well enough. Baseline, variability, and category. So if you guys want to type that into the chat. I'm seeing category 1. I'm seeing about 140 beats per minute with moderate variability and A cells present. Yay, Kimberly agreed with me. So next slide. So when we're seeing this, we say, yes, our baby is nicely oxygenated. We've got some reserve capacity present, which is all very, very good signs here. And looks like we're contracting, doing well. So this moves ahead. So that was at 8:10 in the morning. So now it's almost 2 o'clock in the afternoon. So now our strip has evolved. It looks a little bit different. What variability would you say we have at this point? So it looks like our baseline is about 140 still, but what kind of variability do we have? So I agree, minimal variability, and we're having deceleration. So what kind of decelerations are you going to call these decels? So again, it does look like she's still contracting. Okay, so we've got one person thinking that they're late. And when you are assessing this, that is certainly a potential for that. Maybe earlies, we do see that we've got that gradual decrease from onset to nadir. It looks like they're either happening with the contraction simultaneously or shortly thereafter. But our what I like to say is our red flags are raising. We're a little bit alert to what's going on here. So we probably want to, because we have that minimal variability, certainly do some interventions. What I would say, definitely put her on her side, maybe give her a little fluid bolus. We've got vital signs there for mom. Looks like her blood pressure is within the ranges that they've been. So now we're going to move 45 minutes later. So now 45 minutes later, we're going to initiate pushing. She has normal show, she's complete, and we're starting to push. Looks like those contractions are ranging about 1.5 to 2 to 3 minutes apart. Looks like our variability is potentially a little bit better. Does anyone see anything on this strip that is concerning to you? Are we okay with this? You can either give me a thumbs up or a yes. We're going to let her keep pushing. Okay, so next slide. This is what was documented, that we had a baseline of 120 with moderate variability and A cells present. Glancing at this slide, she's been pushing for approximately 2 hours. Does anyone, are you guys okay with the way that this strip looks? Do you agree with the documentation that was provided for you? Okay, so we'll go ahead and go on to the next slide. This is shortly after. Mom's blood pressure is elevated now at 176 over 110. She has a pulse of 153. We're tracing the fetus. What would you say? Are we having the same tracing, that moderate variability in A cells present. Does everyone agree with what the tracing is looking like? Okay, I'm seeing we might need a pulse ox for mom. Okay, so this mom is, this is the tracing immediately before delivery. I was looking at my notes. So can we go to the outcome? This is a stillborn infant with 000 APGARs, no response to resuscitation efforts. Is anybody surprised about that, looking at the strip that we had? So what do we think happened in this case? Can we go back one strip, Rachel? Thank you. So looking at this strip, absolutely, it would be wonderful if we had had a maternal pulse ox on here so that we could differentiate between maternal pulse and fetal pulse. In this case, the maternal heart rate was being traced instead of the fetal heart rate tracing. So for approximately 2 hours, we did not have any tracing for the fetus. So this is what we call signal ambiguity within this delivery. My question to everyone here is, when you have a tracing that looks like this, and it appears to be a very, very oxygenated baby, you're seeing what looks like moderate variability, looks like A cells. How does something like this happen? So how is it that we end up with a baby that we thought was completely oxygenated to now a baby that is a demise that at birth? So this may be something that Dr. Campbell, after we get wrapped up with the last of the slides, that we can kind of talk about a little bit more.
Yeah, this is fortunately an uncommon event, but it certainly can happen, and I've seen it, and I'm sure you've seen it too, where we've monitored mom and thought we had baby on the monitor. So, boy, it's a kick in the teeth when you see this, but it certainly can happen. It looks like a heart tracing, right? And
it does. It does.
And you're seeing great variability, which you will see with the maternal heart tracing.
So one thing that I will point out here is that most fetuses, and we can talk more about this after we stop the recording, but most fetuses that have been in labor and mom has been pushing for a couple of hours are not probably very, very likely after 2 hours of pushing going to be able to show you A cells with every contraction, because some of their fetal reserve has been used at this point. However, the maternal heart rate will mirror that contraction activity. So the maternal heart rate will increase with those contractions, like what we're seeing here. So one of the key things that we want to look for to kind of assess for that potential signal ambiguity is if I'm seeing a fetus that looks like it's having A cells with every contraction, we're seeing it just like we're seeing on this strip here, that every time there's a contraction, there's an A cell, that very likely may not be the fetus. And so that is that opportunity that we need to put that pulse ox on very quickly. All right, next slide. Yeah, and we can advance. And that was an accidental, didn't get deleted. So I'm sorry about that. So just ignore this outcome slide and we'll go to the next slide that says what happens to baby. So this is just a nice little summary that I thought we could kind of talk about as we finish up, is the antepartum and intrapartum healthcare providers have to consider all of the events that are occurring throughout the antepartum and intrapartum care of that baby. It's so much more than just the fetal tracing or just the maternal or intrauterine interventions, but it's all ultimately the goal of having that best outcome. So were there red flags that we should have intervened throughout the process? Were there opportunities that interventions may have made a difference? You know, and I always ask a question like to our nurses, did we drop the ball somewhere? How else could we have cared for these patients? So next slide. these are just some things to consider. We want to make sure that we're extremely vigilant in both maternal and fetal assessment throughout the labor. Always, always, always make sure that we are having a comparison of the maternal and fetal heart rate, even with a fetal scalp electrode on for the fetus, that we are always double checking throughout the labor process. What is maternal heart rate, and making that comparison. Other things that we want to consider is, what is the physiology of that placenta? How old is that placenta? Are we post dates? Do we have additional comorbidities like preeclampsia, chronic hypertension that could affect that placental perfusion? If we move to the OR, are we assessing that fetal heart rate once we get into the OR? How long is that time period when we're off the monitor to get to the OR? How long we're off the monitor until we get to that incision time? If there is surgical preps going on, how are we capable of doing fetal heart rate checks, spot checks at least throughout that process of before abdominal prep is done? Thinking too about what other medications might be affecting the fetal heart rate, what meds mom might be on. Specifically, we think about our blood pressure medicines, our mag sulfate. Next slide. And then always considering for the maternal, what are her previous pregnancies? What is her story that goes along with that? Her previous deliveries, that maternal adaptation to pregnancy. Are there chronic conditions? Are there acute conditions? Are extrinsic influences that the fetus is responsive to? So that is the cord, the uterus and the placenta, the amniotic fluid, and all of those maternal influences. And next slide, consideration of the fetus itself. And if you could advance it just a little bit, there should be a little, there it is. So we think about, what is the gestational age of the baby? What is the baby's capacity for maintaining its own homeostasis? So when I teach my fetal monitoring classes, I like to talk about the baby's backpack. What kind of reserve capacity does that baby have? If we are early in gestation, we know that all of those intrinsic influences, the baby's ability to maintain homeostasis is very, very limited because they just haven't had time to mature, versus a term baby that should have everything in place and mature. However, if we have a chronic condition for mom, that's going to affect how well that baby has been oxygenated throughout the tracing. And then our last slide. So we always want to consider, and we'll talk about these cases again after we turn off the recording, but what is the tracing trying to tell us? What are we looking for? What should be considered? And are we thinking about the whole picture? So I like to use the image of a camera because to me, it makes a lot of sense that we zoom in on these little individual pieces. And so this is an image that is zoomed in. What do you think this is a picture of? Other than pretty sparkly lights, because that's not the correct answer. Somebody may have seen my presentation before. Go ahead and advance the slide. So yes, this is a field full of dandelions, and we have zoomed in on one of those flowers very, very closely. So when we're talking about our fetal monitoring tracings, when we're talking about our laboring intrapartum moms, we're zoomed in on individual things. We're zoomed in on coaching her when she's pushing. We're zoomed in on doing intrauterine resuscitation techniques in order to help with the oxygenation of the baby. But we always have to zoom back and remember everything. What are all of the things that are going on, and what other things have happened on a different shift even before you came in? And I think that's important too when we're doing checkout, both nursing and provider checkout, for what else is going on with this patient. So that's all I have for slides. So we can talk about, I do want to talk more and get some group interaction about that signal ambiguity just a little bit. And then there was another